I'm Stephanie Cobian, VP of TVGuestpert. I'm excited today because we're having one of our next TVG Webinar Series. A little bit about us though, if you are new to our family, TVGuestpert, TVGuestpert Publishing, and TVOnCameraTrain.com are visionary media companies that seek to educate, enlighten, and entertain the masses with the highest level of integrity. Our exposure grows our Guestpert's core business. That means a lot of things. We help people, experts such as Dr. Celina Nadelman, get on television, print, speaking engagements, all the sorts, podcasts. We work on websites. We create press kits. We publish books. And speaking of, we do have a new book coming out by another author, Dr. Sheila Foreman, called Tame Your Appetite, The Art of Mindful Eating, something that I know I'm reading right now. So that will be coming out in 2022. Everybody keep your eye open for it. We'll have more information on our social media. But right now, again, you're all here to hear Dr. Celina Nadelman talk. Celina will be discussing today how to be your own health advocate. And Celina's got a very particular expertise. I will kind of let her introduce herself a little bit more, but she's a fine needle specialist. I've actually seen her work live. It's quite mind-blowing to me. She's one of the very few doctors in the U.S. to uniquely serve as both a certified cytopathologist and a fine needles aspiration specialist. So I'm going to relinquish it to Celina. You can describe a little bit more about what that means and what you do, because like I said, I've witnessed it live, and I think it is something definitely really important and just this topic. So please, everybody, as you're listening, if you have any questions, please go ahead and leave them in the chat. It's open, and also we have our Q&A box as well. I'll come back after the presentation, and we'll do a short Q&A before we wrap it up for the day. So again, welcome, Dr. Celina Nadelman.
Thank you, Stephanie. I'm happy to be here. Here I am. I am, like I said, a board certified anatomic and clinical pathologist. And I see patients from the Beverly Hills area, Los Angeles, and beyond. I see patients from all walks of life. I also work at Martin Luther King Jr. Outpatient Center, which is in South Central Los Angeles, serving the underserved and underprivileged in our white, black, and brown communities. So let me just tell you a little bit about myself. I was born and raised in Los Angeles, one of the few, as are my children. In fact, I live in the house I grew up in, and my children go to the schools I went to. So there is a little bit of tradition there. I wanted to study psychology. I always was interested in what other people thought and how they felt, and my college counselor in high school recommended that I go back east to Clark University, where I'd say most people start their major in psychology. It was one of the few schools that both Freud and Jung visited when they did a tour of the United States. I got a bachelor's degree in psychology and studio art. I was a double major with a minor in biology, and I mostly concentrated in neuroscience. Thereafter, I lived in Europe, specifically in Florence and in Rome. And during my time in Rome, I had a neuroscience internship through the University of Rome, La Sapienza, with 2 neuroscientists and psychiatrists. I also, because I was a studio art major, I still loved art. I went to the Academy of Decorative and Restorative Arts in Rome, where I learned how to do fake marbling and trompe-l'oeil and grisaille, all those things that were very popular in the early 90s. And I was trying to decide whether I wanted a career in the sciences or whether I wanted to pursue a career in the arts. Thereafter, I came back to the United States, did my pre-med courses, and got into several schools, but decided to stay close to home and attended USC, which is now called the USC Keck School of Medicine, right here in Los Angeles in East LA. And at the time, it was a lot of people, and the main push was towards primary care. So I went into internal medicine. I did my internship in internal medicine at the West Los Angeles VA UCLA program. And although it was very interesting, I felt that it was not a right fit for me. So I was trying to see what I wanted to do thereafter. And I had a research fellowship at USC in wound healing. I was there for 2 years, and I did basic science research in wound healing, working in a lab. Thereafter, I started my pathology residency in anatomic and clinical pathology, and finished at UCLA, and then went on to a cytopathology fellowship at UCLA and finished there. That's just a little bit about my academic background. A little bit about me. I've been married for over 20 years. I met my husband just before medical school. In fact, we met because he had gone to medical school outside of this country and was interested in possibly re-entering medical field, at least maybe a residency program. Currently, he is a healthcare administrator for UCLA, and it makes for nice dinner conversations that don't really gross us out. And I guess our kids have grown up hearing a lot of healthcare related stories. I'm the proud mother of 3 boys. They're very different, but wonderful, funny, and smart people who I love. And I really made a conscious effort to be very present in their lives. And so I try to be mother as well as doctor and businesswoman and wife and daughter. I am the child of a Holocaust survivor. My life, I think, has been definitely colored by the fact that my mother survived the Holocaust in Poland. And we lived all together, multi-generational, living under one roof, all 6 of us. My hobbies include traveling, cooking, baking, doing art, dancing. I'm always up for a good disco party. And I love making friends all over the world. Here's a little bit, my mother, my 3 boys, and my husband. I don't know if you guys can see that. And then here's a couple of my hobbies, my baking and cooking. And this is what I did over COVID. I kind of went a little crazy. I learned how to make a stencil, and I made all these t-shirts for my friends. We're all in this together. I learned how to do shibori, which is a type of Japanese tie-dye, and scratch art, and all sorts of things. I kind of like to keep myself busy and kind of decompress, doing something creatively. And I was just talking to Stephanie how I really don't like writing, but I guess creative writing is what saved me in high school. I'm a visual learner and thinker, and I like to kind of enjoy the visual arts and in doing them, as well as appreciating them, which kind of lends itself to my field of pathology. So what is a pathologist and what is pathology? So pathology is the study of human disease. That's everything that ails us, from infection to inflammation to cancer. So when you look at a textbook of pathology, it's not just tissue pathology, but it talks about things that ail human beings. And it talks about from the nitty gritty of the vessels all the way to our organs like cardiovascular disease and the heart. A pathologist is a doctor who specializes in pathology. And most commonly, we are the doctor's doctor. So we figure out the answers that our clinical colleagues ask about. So if a patient comes in and they say to their doctor, you know, I have a cough, and then the doctor orders an x-ray, and on the x-ray, there's something on the lung, and then they do, let's say, a sputum analysis. They make the patient cough into a jar. That jar then goes to the laboratory, which is overseen by the pathologist. And in the laboratory, it's grown in the microbiology part of the laboratory. And we look for infection and inflammation, such as tuberculosis. On the other hand, sometimes what happens is you find a mass and it's not infectious, and a biopsy is taken of that mass, and that piece of tissue is processed in the laboratory and then made into a slide. And then someone like me, a pathologist, looks under the microscope and decides whether that piece of tissue is normal or abnormal. And one of the things we look for besides inflammation and infection is also cancer. So I remember when I did my internship in internal medicine, I would bring the specimen down to the laboratory, and it felt like it went behind the curtain, like, you know, the Wizard of Oz was behind there. And then you would wait for days and wonder, where is the answer, because I need to treat my patient. And now, as a pathologist, I am behind that curtain. And so I know exactly what it takes to make a diagnosis and then relay it to that referring doctor so that that doctor can help their patient. So the pathologist runs the laboratory. The pathologist also most famously does autopsies. It's as seen on TV and NCIS. All these TV shows like to portray pathologists as only forensic pathologists. And although I've had to do my share of autopsies, I no longer perform them. And most pathologists are in the laboratory or hospital setting. Anatomic pathologists look at tissue, and clinical pathologists look at things that come into the laboratory, such as blood work or chemistry. And what's different about me is that I am not in just a laboratory or hospital setting. I actually run my own clinic, and I have my own laboratory, in addition to working for the County of Los Angeles at MLK Junior. So my subspecialty is cytopathology. After I finished my residency in anatomic and clinical pathology, I went on to a year of subspecialty training called Cytopathology Fellowship. And what is cytopathology, and how is that different from regular anatomic pathology? It is actually the study of cells, or what I call cells in space. Normally, when, let's say, your gallbladder gets taken out, that gallbladder is fixed in formalin and then sliced up and then put in a tissue block of paraffin, and then a slice of that is put on a slide and stained. And when you look at it, it's a whole chunk of tissue. The way that cytopathology works is it's either cells that fall off of tissue, as in urine samples or pleural fluid samples or acidic fluid, or even pap smears, cervical pap smears. It's considered cytology that has fallen off of an organ. And we look at it spread out like cells in space rather than chunks of tissue. Another aspect of cytopathology is aspiration cytology. And that is when you actually do a tiny needle biopsy. It's similar to like a core biopsy, but much, much smaller. So the cells are not stuck together in a chunk of tissue. It's like pushing a straw through sand. The diameter of the straw is that much larger than the sand particles. And then when you eject the sand particles onto, let's say, a slide, and we're using that metaphor, you're looking at the individual sand particles. So the benefits of cytopathology is that you're using the smallest amount of tissue that you can evaluate something. And this can give you a lot of information about what's going on with the patient. As with cervical pap smear screening, women go in and the gynecologist does a scraping of the cervix and puts it in a solution, and that solution gets spun and then processed on a slide and stained, and the cells are spread out so that we can look at them individually and see if there's precancer or if there's cancer and whether the patient needs to be treated. It's a great tool for screening because it's relatively harmless. I mean, it's uncomfortable, but it doesn't cause any harm. It's relatively inexpensive, and we can see a lot. And because of this, we have seen cervical cancer rates drop dramatically. In the 40s, it used to be the #1 cause of cancer deaths in women. And now you hardly hear of anybody dying of cervical cancer. So how did I become the type of doctor that I am? As an undergraduate, I studied psychology and studio art, like I said, and I was always a visual thinker. And I had a great interest in what made people tick. And that's why I did a double major, because I didn't know how to just, only study one or the other. Found that my arts background was a good fit for pathology, which is a visually oriented discipline. You look under the microscope at things. And one of my teachers in medical school, he used to end his lecture, or actually intersperse, and this was the time when we had like slides and slide projectors, and he would put in the middle of his lectures pictures of famous places like the Eiffel Tower or the Taj Mahal. And he would say, you guys maybe have been to Paris or not, but you know that the Eiffel Tower is in Paris, and you know the Taj Mahal is in India. And that is the key to being a good anatomic pathologist, is pattern recognition. So the pattern of seeing the Eiffel Tower, meaning that you're in Paris, there's a connection there. And so if you can see things under the microscope and see a certain pattern and be able to tell the difference between something that is benign or not cancerous to something that is malignant or cancerous, then that makes you a better pathologist. That goes true with cytopathology. So having a visual mindset is key to being a good cytopathologist. In addition, I always enjoyed doing procedures during my training. So I liked doing all sorts of procedures. And in fact, when I was in medical school, I was one of the few women that honored the surgical rotation. And we were invited to a dinner at the end of our rotations. And I was sat with all the female surgeons, and they would say, aren't you going to go into surgery? And I was like, I just don't see myself in it. I want to have, children and a life. And they said, well, what about surrogacy? I was like, okay, that's not for me. So when I was in internal medicine, we got to do all sorts of procedures, which I liked, and I liked the patient contact. In pathology, most of the time you are sequestered away from the hustle and bustle of the hospital or the rest of the clinical world. You are in a laboratory or you're in an office looking at slides, and your contact is mostly with other doctors, other clinicians, other physicians. And so you rarely have that kind of patient interaction. And so I found that I liked this patient interaction, and I liked doing procedures. So when And early on in my pathology residency, I did a rotation in cytopathology and did fine needle aspiration procedures. I found that this was a great fit. And then in my second year, one of the pathologists came to our residency and spoke about how he had a standalone FNA clinic, or fine needle aspiration clinic. And I thought, this is a perfect fit for me. And that's what I wanted to do. So I approach my practice very holistically by wearing different hats. I play the parts of internist by seeing the patients and talking to them and doing a focused physical. And I also wear the hat of radiologist. I use ultrasound to help me find the lesion that I'm trying to do a biopsy of. And I play the part of surgeon or proceduralist by doing the actual biopsy. So by integrating the different aspects and senses of my medical knowledge, I aim to deliver the best care possible. Usually when someone has a lump, let's say we talk about a thyroid nodule, they go to their doctor, and the doctor refers them to either an endocrinologist or an ENT, and then they do an ultrasound, and then the ultrasound guided biopsy, or maybe they might not use ultrasound. Then that specimen then goes to the laboratory, gets processed, and someone like me looks at it under the microscope. In my clinic, I play the part of all three people. So I see the patient, I do the history and physical, I do the ultrasound, I do the ultrasound guided biopsy. I stain the slide immediately to see if I have enough material or what type of material it is. And then later on, once the rest of the slides are processed, I'm the one who's making the diagnosis. That's really important. So here I'm showing a picture of a woman with neck lumps. So here she came to me. And so I see patients who have superficial nodules or lumps and bumps of the body. I don't do fine needle aspirations of deep-seated lesions like pancreas or liver, but things that are superficial like neck masses, thyroid nodules, enlarged lymph nodes, breast lesions, anything that I can reach with a needle that's superficial enough. And what happens is I take a piece of the material out and I smear it onto a slide. And this is a view of my microscope on low power, like what it looks like. This is actually a cytopathology smear. And as you can see, it's kind of like a flat sheet of cells, these kind of indigo cells, and then the red blood cells are in the background here. And I have to interpret that, this kind of flat two-dimensional model into like a three-dimensional idea in my head. And this is actually a chunk of tissue. So this and this are the same thing. This is actually papillary thyroid cancer. And as you can see, there's a chunk of tissue with lots of cells lining a core here. This is what's called colloid. And you can see that it's like fingerlings coming off. I have to be able to see this fingerling in this two-dimensional model transposed into this more, I'd say, obviously it's still two-dimensional on the screen, but a more of a three-dimensional model. So I just want to go a little bit more deeply into how I approach my practice of medicine. And I started thinking about how doctors do their own practice of medicine. And you come to realize that we're not all the same. And some doctors are more persnickety and other doctors are not so specific. I think we all go into medicine because we want to help people and or are intellectually curious about our biology. And we all go into a rigorous medical training. We learn about the basics, anatomy, physiology, biochemistry, et cetera. We learn so much that it's said that being in medical school is like taking a drink of water from a fire hose. And then we go on to specialize in specific areas of medicine, such as internal medicine, which I started out in, or pathology. And then we become experts in our field and focus so much on that specialty that sometimes some of us get tunnel vision. And often because of this, physicians don't use all of those clues that are at their disposal to try and figure out what ails their patient. And this is the tragedy as well as the progression of modern medicine. We become so specialized that a lot of the general doctors or primary care doctors tell you, I have a lump, oh, go see the radiologist and have a picture of that. Or, they're not trying to figure things out holistically. And I really try as much as I can to take all the knowledge that I have acquired, not just from my subspecialty, but also from my experiences in the laboratory, in the molecular laboratory, as well as in my internal medicine internship, and bring it all together to help better serve my patients. So the role of a doctor is to assess the problem and find an answer and treat the patient. And as doctors, we're really taught to think algorithmically. And in doing so, we sometimes tend to think of things only in a linear one-way fashion, rather than maybe opening our minds and solving problems, maybe multitasking in a multidimensional manner. And as I said before, a lot of doctors depend on ancillary methods rather than actually taking time to do a history and physical and actually touch the patient. I remember going to a doctor and their medical student did a whole history and physical on me, and then they came in, the attending, and they just said, well, I think you have XYZ. And he never actually touched me. He never did the physical exam, which I found strange because the medical student is still learning. And he still is my doctor, even though the medical student did all the time, spent all this time with me. It still behooves the practitioner to lay hands on the patient. It's very important. There are things that doctor has learned and picked up over the years and has learned that the medical student still hasn't learned yet. So I really try to use all the clues that are available to me, my medical knowledge, my patient history and physical, the data behind certain lesions, the ultrasound, everything, even when I'm doing the biopsy, the way the biopsy feels and how it smears. This is all to help my patients and to really render a correct and accurate diagnosis. So the issue is this: we can't all be learning everything all at once. And so medical information is growing so fast and so exponentially that when I went to medical school, I learned so much more than, let's say, my brother-in-law who went to medical school 20 years before me. And I'm sure medical students are learning things way more than I am. And now there's the internet and there's so much information out there. And so doctors are getting much more specialized, which is a good thing. I think, patients now have more access to information because of the internet, which I think is fantastic. It empowers patients. But on the other hand, a little knowledge can be a dangerous thing as well. And people kind of go off on the deep end and start to, worry and get anxious much more than they actually need to. Most patients who come in to see me actually do not have cancer. The majority of them have benign lesions. But of course, the internet is there to, inform you, and you may read a little bit too much and not understand or interpret everything and then get anxious and scared. So I think it's important that we do have a lot of information that is accessible to us. And there is definitely a shift from, let's say, the 70s and 80s to now, where doctors were more paternalistic and, kind of you looked up to the doctor and whatever the doctor said, that's how things went. to a more self-directed way of controlling our own health care. And we are becoming, patients are becoming their own healthcare advocates. The pros, like I said before, doctors know a lot in their specific field. They've become experts. But the cons are there's a loss of continuity, and there's a loss of this kind of holistic approach to healing. Years ago, your doctor, if you needed to go to the hospital, your doctor was the one that admitted you to the hospital, and then he or she went to round on you at the end of his day to see how you're doing every day at the hospital. Now what happens is your doctor admits you to the hospital, and then there's a team of hospitalists or internists that only shift work in the hospital, and they take care of you. And there may not be, it might be a case of like operator, where there's loss of communication between your regular health and what your doctor has known of you for years, and your acute issue that's being dealt with in the hospital. So this whole holistic approach is being lost. And because of that, I think patients need to be more involved in their own healthcare, and they need to be their own healthcare advocates. So, which brings me to, how do we become our own healthcare advocate? And this goes across all types of doctors when you go to a doctor's visit, whether it's a primary care physician, a generalist, or a specialist. As a doctor, we try and glean as much information from talking to the patient as we can before we go on to looking at ancillary studies such as x-rays or CTs or MRIs or blood work or chemistries or whatever it is. So it's important that patients can communicate correctly and succinctly to their doctor exactly what is going on and what ails them. So it would be a good thing to first try and write down your symptoms in a very detailed and relevant, concise manner, so that when you do see the doctor, he or she can get as much information from you and get on to finding solutions to your problem. Secondly, you should have always a copy of your medical records. You should have a file at home with a hard copy of your medical records, so that in the event that you need to go to someone else or somewhere else, sometimes people go to the Mayo Clinic, or they need to go to New York or wherever it is, or MD Anderson, they can actually take that hard copy and present it to that specialist, so the specialist can actually read it in their hands. I know we're all getting everything electronically, but sometimes it doesn't necessarily arrive at that specialist's place. You may have asked for your records to be faxed or emailed to your specialist, but sometimes that office is busy and they haven't done it, and you get to the office and the specialist hasn't yet received your prior information. So it's nice to have a copy of your records in an organized manner, so that when you do see that specialist, they can help you as best as they can. Next, do not be afraid of asking questions of your healthcare provider. It's okay. You're there to be part of your healthcare and to help your practitioner help you solve the problem that is ailing you. And if they don't know the answer, it's okay. Not everybody should know everything. They may be able to refer you to someone who does, or point you in that direction. Thirdly, if you have someone come with you, it would be really nice. Let's say if you have something complicated or complex, they can be a scribe for you. I had a patient the other day who had dementia. They were an elderly patient, and they had their healthcare advocate come, their aide, and the aide was writing everything down so that they could relay whatever was going on to the patient's son. And I thought that's a really clever thing, to have someone there with you and write things down, because like in any stressful situation, like a doctor's appointment, a lot of people don't remember exactly what's being said during that visit. There's a little anecdote that my mentor, who was a great pathologist, told me. He went to the doctor with a friend of his who was an ophthalmologist, an eye doctor. His ophthalmologist had something suspicious on his x-ray. So he asked Richard to come with him to the doctor's visit, because Richard was a pathologist and could maybe help translate or help with whatever assessment was being made. So he went to the lung specialist, and the lung specialist said, yes, it's not such good news. What you have is lung cancer. And he explained the stage and the grade, and the visit ended. He asked the patient if he had any questions. The patient asked questions, and then they left. And the ophthalmologist turned to Richard and he said, so Richard, do you think it's bad? So obviously, even though he himself is a doctor, as a patient, you don't necessarily hear what the doctor is telling you, because it's very stressful and you have your own conversation that's going on in your own head. So it can be very, very helpful to have someone come with you and be your ears and eyes and write things down for you, so that later on you can reflect on it and absorb whatever information is being said to you. And lastly, if something does not add up or doesn't feel right to you, or you did not like that visit, go for a second opinion. Whenever people ask for my slides to go to another institution, I'm always very happy to give them, because I know I'm only human. And although I don't like to think of having made a mistake, I want my slides to be reviewed by someone else to corroborate, or to maybe find something that I might have not picked up, because the last thing I would want is for a patient to undergo a procedure that may have harmed him or her when it wasn't necessary. So going for a second opinion is nothing to be ashamed of. You should feel comfortable, and you should not be ashamed or embarrassed to go to someone else for a second opinion, especially when it is a very serious matter to your health. So that's all I have to say about my specific field. But I did want to talk a little bit about COVID, because COVID's on the brain, and I've become obsessed with SARS-CoV-2 since it broke out of the gates. I actually found out about it before it came to the United States. A friend of mine who lives in France, her son was going to China to study, and he had said that there was some sort of virus going around, and he was worried about it. And then, well, here we go. We started the era of COVID-19. And what happened during the first really serious lockdown of COVID was that everybody, hid out, as you all know. But what I found was cancer actually did not really care about the pandemic. And that's just how it goes. Like, this is just biology. Malignancies happen, and people were too afraid to have things checked out unless it was really dire. And so during those first few months of lockdown, every patient that I saw had a malignant diagnosis. It was actually quite impressive. At first, my clinics were closed at MLK, but the ENTs and the endocrinologists and the surgeons said, we have patients that are still coming because they have, nodules or masses or, lumps or bumps that need to be looked at. And, putting it off until we know when things are going to open was not an option. It was actually quite impressive and stressful, and I think that everybody was under a great deal of stress. So we still do need to take care of ourselves during stressful times. And people can point fingers to different doctors or administrators. You did this wrong, or this wasn't done correctly. And yes, maybe certain things could have been maybe messaged better, but we haven't dealt with a modern pandemic in the 21st century. And I think that as we move forward, we need to be kind to not just other people who are trying to figure things out, but also kind to ourselves. We need to be on top of our medical needs. We need to be resilient and try our best to take care of our loved ones as well as ourselves. And we need to, it's difficult to navigate to see what is important and when it is necessary to see a doctor in person. I think COVID really has changed how we've thought and how we have taken certain things for granted, like being able to go to a restaurant, but also it's changed how we work, even in the medical field. It's opened certain doors. Working remotely has become very popular. Many doctors now see patients via video, which can be convenient for both parties, both the doctor and the patient. If the patient can't get to their doctor, some patients don't have transportation, or they're very sick and they're in bed. And so we need to think about, the benefits of having lived through something so dramatic and life-changing. We also have to think about, how we take these new lessons and what we do with them. As I said before, my practice never did close because I can't do a biopsy over the phone. So I was always up and running, and I just felt it was very important for me to deliver the kind of healthcare that I was always delivering before the pandemic as well. And aside from the loss of life, the incredible loss of life from the pandemic, the fear and the anxiety, the mental and physical toll, COVID has shown, like I said, that we are resilient and creative. Interestingly enough, because I was so obsessed with it, I researched and wrote a paper on SARS-CoV-2 and my thoughts about what makes bad outcomes from COVID-19, such as endothelial dysfunction, and how we can protect ourselves through supplements and vitamins. And like many, I showed you some pictures. I turned towards my creative side. I know a lot of people were making sourdough bread. I did that a couple of times, but I think it's not a lot of bang for your buck for me. So I tie-dyed, I made t-shirts, I learned how to do shibori, I learned scratch art, painted and baked, and walked a lot as much as I could. I think it's important to keep your mind open and clear, as well as your physical being. And I think the good thing out of COVID, like I said before, we're being more appreciative of doing things that we took for granted. Like socializing and going to a restaurant. I think now we really crave that interaction that we just, took for granted. And I think we appreciate each other more. And I hope that stays with us. I hope our generation and the generations to come will learn a great lesson from this time period. Questions?
Celina, that was so fantastic. I think you gave a lot of great information, and learning about what you do and your personal story is quite fascinating. So I actually do have some questions, and I looked at our Q&A is open for people as well. So I kind of want to backtrack to the beginning. One of the things that you hit on was serving and working in underprivileged communities, like the brown and Black communities. I'd love to learn a little bit more. What, perhaps maybe in the last year, have you kind of learned from how these underserved communities are working? How do you, I'm not quite sure what the question is, I guess, but I'm kind of just trying to get, like, what are we seeing different and what can we do differently, both just to advocate for ourselves, someone who's in the Black and brown community who may not feel that they have a voice, versus someone who has the opportunity to go to maybe a different hospital, things like that. Like, so how are they able to advocate for themselves when they're stuck at the hospitals that they go to, the communities that they go to, or with the insurance that they're stuck with? It's kind of a loaded question. There's a lot going on with that.
I don't know the workings of like how to become part of LA Care, but that's, I mean, I love working where I'm working. You know, people sometimes kind of diss the county system, but I work with really incredible people. Like, they are very, very dedicated. I have a great team. I mean, my clinic is actually in the oncology suite, but I also work with ENTs and surgeons and internists and endocrinologists, and they're very hardworking, bright, innovative people. I mean, I would, if, you know, I would go to them, you know, like personally, like I have complete confidence in their abilities. And I feel very fortunate that we're part of this team. So I know that people say, oh, you know, MLK, you know, Killer King and blah, 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 you know, it had this reputation. Of course, MLK Outpatient Center is separate now from MLK Hospital. The hospital is actually run by a private entity. But this, you know, the county, I think really has stepped up and provided. We were one of the first to provide vaccines. I was really, really on the bandwagon. I went and worked the vaccine clinic up at Balboa Park for the public. And at MLK, I was working the vaccine clinic there. I actually contacted Christina Galli, who is like the person right under Barbara Ferrer, and was telling, like, giving her ideas, like we should go door to door, because some people, you know, like the vaccines, sometimes they were being thrown out. If, you know, the Pfizer vaccine had like an expiration. And I said, we need to have like, you know, a radius of people that we can call that can just come in immediately, or have a list that we can kind of just disperse the leftover vaccine, or knock on people's door. You know, like a lot of people in that area don't have access. They don't have transportation. And I was like, we can, you know, do a mobile clinic, and we could go, and I think the county did start doing mobile clinics and you know, help the homeless, and you know, actually going to them rather than having them come, you know, because they don't necessarily have the means or the wherewithal to come and get protected.
Yeah, I think that's fantastic. I love the work that you provide to these communities as well. And, you know, even just, we did know that you were working at Balboa and everything. So I think it's fantastic you've given your own time and opportunities there. We do have a question that says, you did bring up vitamins and supplements. Now, I know that there's a lot kind of surrounding vitamins and supplements, what's okay, what's not. Do you have any that you might suggest or any to avoid per se?
Well, I mean, traditionally, I think if you're eating well and right, you should have, you know, a well-balanced diet should be enough vitamins. But the article I wrote was based on the findings, and you can see it on, I guess, media.com and on my website, www.drnadelman.com. about supplements and vitamins to help kind of bolster your vessels, or what's called endothelium, because the endothelium is what is responsible for not only like atherosclerosis, but also the transfer of oxygen, so get oxygenating in our blood. And I was seeing that, you know, the bad outcomes of COVID early on were actually clotting issues and inflammatory issues more than, let's say, like just lung issues. And so I kind of extrapolated that if our vessels, you know, with good diet and exercise, like good cardiovascular health, is more resilient and robust, then maybe we won't have such bad outcomes from COVID. And with studies that have been done on cardiovascular health, just from the past, different studies have shown that certain supplements, such as like, you know, vitamin C and vitamin D and magnesium and resveratrol and polyphenols, these things like, you know, that, you know, the red wine and the, you know, tea, the green tea, the black tea, all these things, you know, the cocoa, these are antioxidants, CoQ10, that actually help our cardiovascular system. And perhaps if we are able to make our vessels more resilient, then maybe we won't have bad outcomes from COVID. And so that was where my thinking was. So I'm not a vitamin specialist and I'm not a nutritionist, but just from the research that I was reading on cardiovascular health, on endothelial health, which is the lining of the vessels, I kind of came up with, you know, I kind of married the two ideas together. So if you want to learn more, you can look at the article that I wrote.
Absolutely. Yes. And you do have a great article on it. I kind of want to just go a little touch base. We do have a question on, do your patients go to see you or do you go to see patients?
I used to, when I first started, I used to bring my microscope and my stains and all my stuff in like a tackle box. And I used to go from doctor to doctor. They would call me and they would say, I have a patient here, and I would go. But that just became untenable. So patients come to see me. I have an office here in the Beverly Hills area, near, you know, and patients make appointments just like they're going to see their doctor. You know, I sit down with my patients. I talk to them. I place my hands on them. You know, I do an ultrasound and then I do the biopsy. So yeah, the patients come to see me.
So how long does it take once you do, and again, I've witnessed it, so I kind of know, but how long does it take to actually know if once you pull out the cells, you know that it's cancerous? Versus
it really depends.
Versus how long might it take if they don't go through you, if they don't go through the doctor?
Well, immediate. Like if I see cancer, I see it immediately. Thyroids can be trickier because they sometimes, it kind of hides and you need to look at fixed smears. So I guess the next day, I usually tell the doctor, versus someone else, it takes at least a week, if not longer, a week to 2 weeks.
Yeah, 2 weeks I think would be a long time if you're waiting for an answer if you have cancer. That
well,
doesn't sound like a...
I mean, think about how long does it take you to get your Pap results? I'm asking you.
I don't remember. I know I've done it, but I don't remember how long it took.
Right. Like, let's say, you know, or if you've gotten a biopsy of your, like, let's say you had a mole removed. How long does it take for you to get the results from your mole?
Right. I was saying, if you're worried about cancer, that would be very scary. I wanted to go into one more question before we definitely talk about, we want you to share where people can find you. Is you do a lot, you've done a lot of traveling. Have you noticed anything that the U.S. could potentially learn from other healthcare systems for, you know, its people? Is there anything that you've learned while you've done a lot of traveling?
It's interesting because there are pros and cons, I think. And healthcare here has changed. So when I traveled and I was privy to healthcare was in the 80s and 90s, and it's changed. Our healthcare system has changed. Like I said, we're more like disparate, I think, in medicine, and not as engaged. So there's that continuity of care that you had in years past does not exist as much anymore. There's categories, like there are people who are in the hospital only, and there are people who are only in their office, and so it's kind of separated. Whereas before, you would see your doctor, and your doctor would visit you in the hospital. So that type of medicine, the fact that we have hospitalists versus someone who's seeing you in the office, and that kind of chunks of different types of medicine is good in the sense that you have maybe more specialized care, bad in the sense that there's no continuity of care. And I think that the relationship changes. Like, you don't have a relationship with the people who are treating you as much as in the past. And even though it's still a capitalist society, it's kind of moving towards socialism, even though we're paying for it. So we're paying through insurance companies, and yet we don't get the kind of care that we should be getting from paying private insurances. We're getting care that's closer to socialized medicine that's, let's say, being delivered in Europe. So I think the thing that we can learn about it is that everybody has the right to health care. I think that, everybody wants to have great health insurance and health care. I think that we don't need to have a middleman. It would be nice to have, I don't know the Australian medical health system, but they have both, the government as well as private, and the government pays for certain private things. And I know someone who is, he does, gender rearrangement or sex rearrangement surgeries, and he gets paid by the state as well as privately. So if you want to go and have gender reassignment surgery, you can still use your state insurance, your Medicare for all insurance, and then pay a premium on top of that.
And let me tell you, we do have listeners from Australia and the UK. So
yeah, I don't know specifically. I know
right.
that, and I think that, I know a lot of people don't, it's kind of a balance, when you have things more socialized, and the county is like a more socialized, or the VA is more of a socialized system. Everybody gets good care, but then there are people who it doesn't matter, like I went to the Soviet Union when it was the Soviet Union. I remember going and buying a poster, and I waited in this huge long line, and I got up to the front of the window, and I wanted to pick the posters. I was about to pick them, and the woman said, "Oh, it's my tea break," and shut the door and had tea in front of me. Like, they didn't care. Like, there's no incentive. So I think when there's no incentive, quality goes down. So, I think finding a balance between the meritocracy and incentivizing business healthcare in addition to providing healthcare for all is something that we're going to have to work on. There needs to be something, not what we have now. I think that it's not tenable as we do have right now. I mean, I think in England they have, the national healthcare system, and then I met another cytopathologist at one of the meetings, the national meetings, and he had an FNA clinic, a private FNA clinic. So he saw private patients, you know.
And that's a great note to end on, Celina. It's a great story and a great point. And I think we can all agree, you know, we still need fixes in the healthcare system. So I appreciate you helping people learn to advocate for themselves, what we can do to, you know, hopefully help ourselves and within our health. I was just going to ask you, if you can share where people can find you. So perfect slide.
Special thanks to TVGuestpert, Jackie, Stephanie, Laura, and your team, my assistant Sydney, and my dog Kenya, who always sits under my legs whenever I'm working. For more information, please visit me at my Instagram account at Dr. Cancer Answer, or my website www.drnadelman.com, DRNADELMAN.com. Thank you very much.
I love that. Dr. Cancer Answer. That's easy to remember. So everybody go find her on Instagram. Thank you, Celina, for a wonderful presentation today. I hope everybody got something from it that they can now start using in their lives.
You can always email me if you have a question.
Absolutely. Yeah. Celina is very open and has a lot of answers. So again, thank you, Celina. Thank you, everybody, for joining. We'll catch you guys on the next one.